एफडीसी ने हाल ही में लॉन्च किया है एनर्जाल जीरो। ये बॉडी को हाइड्रेट।
ये तो कमाल ही हो गया जी, आपने तो मेरी लाइफ बना दी। थैंक यू जी।
एनर्जाल जीरो, अब जीरो ही है हीरो।
बॉडी को हाइड्रेट करे, इट्स टेस्टी। और गुड्डू भैया बनाइए 2 ग्लास फ्रेश ऑरेंज जूस।
डॉक्टर मेहता, आप नहीं पियोगे जूस? जूस?
अरे मिश्रा जी क्या बात कर रहे हो? अरे मिश्रा जी क्या बात कर रहे हो? डॉक्टर साहब ऑरेंज जूस कैसे पी सकते हैं? डॉक्टर साहब ऑरेंज जूस कैसे पी सकते हैं? उनको तो डायबिटीज। एनर्जाल जीरो।
हारूंगा कैसे?
बापू तुम्हारा जीतने कैसे दूंगा? एनर्जाल मेरे डायबिटीज का फायदा उठाया जा रहा है
मेरे हीरो के लिए एनर्जाल जीरो।
एनर्जाल जीरो।
एफडीसी ने हाल ही में लॉन्च किया है एनर्जाल जीरो। ये बॉडी को हाइड्रेट करे, इट्स टेस्टी एंड हैज जीरो शुगर।
रेडी फॉर द गेम?
एब्सोल्युटली।
एनर्जाल जीरो, अब
आज का गेम तो मेरा ही है।
देखते बेटा, सीखा तो मुझसे ही है।
बेटा हूं आपका, हारूंगा कैसे?
बापू तुम्हारा जीतने कैसे दूंगा? एनर्जाल मेरे डायबिटीज का फायदा उठाया जा रहा है
मेरे हीरो के लिए एनर्जाल जीरो।
एनर्जाल जीरो।
एफडीसी ने हाल ही में लॉन्च किया है एनर्जाल जीरो। ये बॉडी को हाइड्रेट करे, इट्स टेस्टी एंड हैज जीरो शुगर। आज का गेम तो मेरा ही है।
देखते बेटा, सीखा तो मुझसे ही है।
बेटा हूं आपका, हारूंगा कैसे?
बापू तुम्हारा जीतने कैसे दूंगा? एनर्जाल मेरे डायबिटीज का फायदा उठाया जा रहा है
मेरे हीरो के लिए एनर्जाल जीरो।
एनर्जाल जीरो।
एफडीसी ने हाल ही में लॉन्च किया है एनर्जाल जीरो। ये बॉडी को हाइड्रेट करे, इट्स टेस्टी एंड हैज जीरो शुगर।
रेडी फॉर द गेम?
एब्सोल्युटली।
एनर्जाल जीरो, अब जीरो ही है हीरो।
आज का गेम तो मेरा ही है।
देखते बेटा, सीखा तो मुझसे ही है।
बेटा हूं आपका, हारूंगा कैसे?
बापू तुम्हारा जीतने कैसे दूंगा? एनर्जाल मेरे डायबिटीज का फायदा उठाया जा रहा है
मेरे हीरो के लिए एनर्जाल जीरो।
एनर्जाल जीरो।
एफडीसी ने हाल ही में लॉन्च किया है एनर्जाल जीरो। ये बॉडी को हाइड्रेट करे, इट्स टेस्टी एंड हैज जीरो शुगर।
रेडी फॉर द गेम?
एब्सोल्युटली।
एनर्जाल जीरो, अब जीरो ही है हीरो।
आज का गेम तो मेरा ही है।
देखते बेटा, सीखा तो मुझसे ही है।
बेटा हूं आपका, हारूंगा कैसे?
बापू तुम्हारा जीतने कैसे दूंगा? एनर्जाल मेरे डायबिटीज का फायदा उठाया जा रहा है
मेरे हीरो के लिए एनर्जाल जीरो।
एनर्जाल जीरो?
एफडीसी ने हाल ही में लॉन्च किया है एनर्जाल जीरो। ये बॉडी को हाइड्रेट करे, इट्स टेस्टी एंड हैज जीरो शुगर।
रेडी फॉर द गेम?
एब्सोल्युटली।
एनर्जाल जीरो, अब जीरो ही है हीरो।
आज का गेम तो मेरा ही है।
देखते बेटा, सीखा तो मुझसे ही है।
बेटा हूं आपका, हारूंगा कैसे?
बापू तुम्हारा, जीतने कैसे दूंगा? एनर्जाल मेरे डायबिटीज का फायदा उठाया जा रहा है।
मेरे हीरो के लिए एनर्जाल जीरो।
एनर्जाल जीरो?
एफडीसी ने हाल ही में लॉन्च किया है एनर्जाल जीरो। ये बॉडी को हाइड्रेट करे, इट्स टेस्टी एंड हैज जीरो शुगर।
रेडी फॉर द गेम?
एब्सोल्युटली।
एनर्जाल जीरो, अब जीरो ही है हीरो।
आज का गेम तो मेरा ही है।
देखते बेटा, सीखा तो मुझसे ही है।
बेटा हूं आपका, हारूंगा कैसे?
बापू तुम्हारा, जीतने कैसे दूंगा? एनर्जाल मेरे डायबिटीज का फायदा उठाया जा रहा है।
मेरे हीरो के लिए एनर्जाल जीरो।
एनर्जाल जीरो?
एफडीसी ने
on skin health care beyond skin care. It is an initiative of IADVL Maharashtra in collaboration with the PCOS Society of India and Psychodermatology Association of India under the educational grant and technical support from FDC Limited. I welcome all speakers and panel members and all the doctors who are watching this program live. It is my privilege to welcome and introduce the speaker and moderator for today's session. Before handing him the session, Dr. Aseem Sharma. I'll just share his slides. So, Dr. Aseem is Assistant Professor of Dermatology, LTM General Hospital, Sion, Mumbai, and he is also Chief Dermatologist at Skin Saga Center for Dermatology, Mumbai. He has more than 102 articles and chapters at national and international levels and presented more than 300 presentations both nationally, internationally, and virtual. He is Executive Honorary Secretary of IADVL Maharashtra, Chairperson IADVL Yuva Cell, also member IADVL Expert Group on PRP, and he is retired Squadron Leader, Indian Air Force. In research, he is international researcher at Cochrane Skin Group and F1000 Prime International. And in editorial, he is editorial board member of Skin Hair Therapy and Transplantation Journal and multimedia journalist in New Delhi Times. Welcome, sir, and I hand over the session to Dr. Aseem Sharma, sir, for further proceedings. Thank you, sir.
Thank you so much, Shailendra, and I welcome everybody to this warm Sunday afternoon. Just give me a second to share my screen. So I'm very proud to moderate today's session where we'll speak about skin health beyond skin care. Before I move into the nitty-gritties, I want to quote an article which dates back to circa 1919. One's skin may be of great diagnostic assistance and may reflect as a mirror fundamental truths relative to pathology of diseases in general. Conversely, and this is the most important part, internal dysfunction can often cause the skin morphology to change, which needs equivocal attention. So, as all of you know, we at IADVL, which is the Indian Association of Dermatologists, Venereologists, and Nephrologists, we're observing the World Skin Health Week this week. And I'm very, very proud to moderate today's session where we have eminent top experts from the PCOS Society of India, the Psychodermatology Association of India, and the IADVL Media Cell. So I will not bore you too much with further information. We'll jump straight to it. Now, we want to discuss about the holistic approach to skin disease because there is so much research going on now that we do need to leave our cocoons as dermatologists for many, many cases, even simple skincare cases, where we do need to consult, cross-consult, and take opinions from other specialties. So today we have 3 lectures planned for you, one by a gynecologist, one by an endocrinologist, and one by a psychodermatologist, and a panel discussion which will follow suit. We will try to keep today's session very practical and case-based so that all of us can benefit from the same. Without further ado, to deliver the welcome note, I request Dr. K.E. Mukadam, who is the president of IADVL Maharashtra, to kindly take the floor and give us the welcome note. Sir is a dermatologist practicing at his very famous clinic in Turner Road, Bandra. He's, apart from the current president of IADVL Maharashtra, he's the organizing secretary for Dermacon International 2023, which again will take place in Mumbai. He's the chairperson of the IADVL Community Dermatology Committee, the former honorary secretary of IADVL Maharashtra, and an eminent guest speaker and invited faculty at many prestigious national and international conferences and workshops. Over to you, sir.
That was our most active and very ebullient Honorary General Secretary, Dr. Asim Sharma. Thanks a lot for a really good introduction. And respected teachers, seniors, guest speakers, and dear colleagues. Greetings from IADVL Maharashtra. IADVL is observing World Skin Health Week 2021. On this occasion, we are proud to bring you experts from integrative fields and stalwarts from the fields of gynecology, endocrinology, and psychodermatology. Over the next 2 hours, we will probe and explore how the skin interacts with other organ systems and how we are moving towards a holistic approach as informed you by our secretary. We have 3 lectures and a panel discussion which follows. As a president of IADVL Maharashtra, it is my proud privilege to open the session. I hand over this mic to our Honorary Secretary, Asim.
Thank you so much, sir, for that wonderful introduction. Now, without wasting any further time, our first speaker for today is none other than Dr. Duru Shah. She's the founder president of the PCOS Society of India. And ma'am is going to speak to us about a topic which is very, very important for us dermatologists nowadays, the androgen excess conundrum. Before that, ma'am is the director of Gynac World, which is a center for women's health and fertility in South Mumbai. She's a consultant, gynecologist and fertility expert at hospitals Breach Candy and Just Lok in Mumbai. She's an honorary fellow of the Royal College of Obstetricians and Gynecologists. And amongst her various accolades, she's the first and only Indian to receive the International Federation's Distinguished Merit Award for services towards women's health. And on a personal note, I'm very thankful to ma'am as she's joining us all the way from the US after a day of jet lag, which speaks volumes about her dedication to the cause. Over to you, ma'am.
Thank you so much for inviting me, Dr. Asim, Dr. Mukadam. It's a pleasure to be here and share my thoughts with you and to represent the PCOS Society of India, which has been doing work related to PCOS specifically, and where we have a lot of focus on dermatology also. So I'm going to start with my presentation and discuss the various issues related to PCOS and dermat situations. So I'm going to start off my broadcast. Give me just half a minute. Can you hear me?
Yes, ma'am, we can hear you loud and clear.
Right.
And your slides are also seen.
Presentation is not on slide mode.
Just a minute. It's not opening into the slideshow.
No problem, ma'am. It is visible.
Okay. All right. So the first, it's not moving.
Yes, ma'am. We can see your presentation, ma'am. Just
Yeah,
make
but
it full
it's not going into the full screen. That's the problem.
on the top. Just you need to press, ma'am, play.
Yeah. Are you seeing it now?
Yes, ma'am.
Yes, ma'am. Perfect.
Oh, perfect. Okay, so I'll start with the case history, which is Mrs. A.S., who first came to me at the age of 15 years and now is about 22 years old. On the first visit, she had a history of irregular periods. She had acne, hair fall, hirsutism, and we had examined her with a BMI of 31, with a waist-hip ratio of 0.95, with an FG score of 11, acanthosis nigricans quite a bit positive, acne plus, blood pressure 140/90, and this was something which clinically we made a suspicion of polycystic ovarian syndrome. Why I say suspicion is because at the age of 15, according to the latest guidelines, we do not confirm a patient as having PCOS until she reaches an age of about 8 years after her menarche. So these various investigations were done, and we did the ultrasound of the pelvis, and it showed polycystic ovarian morphology and a fatty liver on abdominal ultrasound. The post-glucose blood sugar was 196 milligram percent, and a post-glucose serum insulin was 200 international units. Triglycerides was 294, and vitamin D was 8.1. Now, these are only the abnormal results which I have listed here. The rest of the results were all normal. She was advised a weight loss of 25 kilos, and she was started on metformin 2000 milligrams a day with a lifestyle modification and vitamin D calcium supplements. And she was also offered anti-androgens and progesterone for withdrawal bleeding. Since she had come to us with almost 3 months of amenorrhea, she was given progesterone to have a withdrawal bleed. So this was the acne we saw on her face. This was the acanthosis nigricans which she had. You can see the striae on the back. She also had a lot of hirsutism. As you see, it's all over the ears, it's on the face, and it's also on the neck. So this was what was seen at the age of 15 years. We started her on treatment and encouraged her to have a weight loss, which she did in 8 kilos at the end of 6 months. She followed a really healthy lifestyle with exercising 6 times a week and eating very healthy. At the end of 6 months, her, the acne, the hirsutism, the acanthosis, all the signs which we saw earlier had reduced, but of course were still present. Her investigations, which we repeated, showed that the androgens, insulins, and sugars all had come down to normal. And we have been following her up regularly since the last 7 years. All investigations have remained within the normal range. She's been getting regular periods since the last 6 years, has improved her skin concerns, and of all medications today, she's getting regular periods. She's lost approximately 25 kilos, and she's better psychologically, where she was earlier very depressed, and she has increased self-confidence and self-esteem, which she did not have at that point in time. So if we are talking about PCOS in such situations, we find that, even in the US, there was an online survey by the American College, and they looked at what is the response of patient dissatisfaction over diagnosis and treatment, because we find a lot of patients have been misdiagnosed and missed for PCOS. And therefore, when this survey was done, they found that the results of this survey, which was filled in by more than 600 gynecologists, they found that at least almost 27% of them did not even know which criteria they had used. The gynecologists who were well conversant with reproductive endocrinology, they had a higher chance of making a correct diagnosis, but there were almost 85% of them who were aware of cardiometabolic comorbidities, but very few were aware of depression, anxiety, and reduced quality of life. So there was a difference between people who knew about reproductive endocrinology versus those who did not, the difference being 56% versus 41%. So in short, it's important for us to know that physician education is very, very necessary today, because we need to make them understand what is really happening to a PCOS girl when she comes to us with these symptoms, and what we need to do to make her life better and prevent complications and morbidities. So in short, we have to target the knowledge of internationally accepted Rotterdam criteria as they exist today, ensure consistent care, and also monitor across the entire reproductive period of their lives. And hence, we started the organization called the PCOS Society of India, which includes a multidisciplinary approach. We have the endocrinologist, dermatologist, all bariatric surgeons. We have a psychologist, anyone who's treating, nutritionist, who are treating PCOS or who are monitoring these patients have become our members. And we invite you also to become the members of the PCOS Society of India, where there's a very focused discussion on knowledge related to PCOS. If you look at the pathophysiology of PCOS, it basically is associated with insulin resistance, whereby there is extra insulin in circulation, as you see over here, and it acts on the liver, reduces the sex hormone binding globulin, and therefore there is more of free androgen circulating in the blood, which at the same time in the liver, there is an increased insulin-like growth factor released, which is known to cause the obesity. It makes the person grow and creates more obesity. The insulin resistance or the hyperinsulinemia, which occurs, causes ovary thecal cell hyperplasia, which increases the LH secretion, and there is hyperandrogenemia. So in short, we have a situation where there is hyperandrogenemia, there is hyperinsulinemia related to insulin resistance, there is associated obesity, and there is polycystic ovarian syndrome. So this is all interconnected, and therefore we need to have the assistance of both the gynecologist, the endocrinologist, and the dermatologist, especially in a young girl. So these patients, now if you look at what are the Rotterdam criteria we are looking at, basically we need any two out of these three criteria which should be present to diagnose PCOS. And at the same time, we make sure that we have excluded other etiologies such as a thyroid disease, hyperprolactinemia, and also we have to rule out non-classical congenital adrenal hyperplasia. The clinical presentation of women with PCOS may occur mainly in the adolescent period, where most of the dermatologists see this period of the girl's life. Of course, they do see it later, but it's important that, this is the stage where you can prevent problems for the future. And hence, I'm going to focus on this area wherein I'm talking about why they approach us. They approach the gynecologist for menstrual irregularity and usually the dermatologist for their cosmetic concerns. And the reproductive age period, they approach us for their fertility issues, early pregnancy loss. And during pregnancy, it's a well-known fact that they do develop gestational diabetes and pregnancy-induced hypertension, which can make them lose their babies both within the uterus and sometimes with a stillbirth and with sometimes intrauterine growth restriction. So these are areas which, if we are aware of as physicians, which can happen, we need to alert our patients that this is what could happen to you. So you need to be constantly under monitoring. And in the menopausal status, they do tend to develop metabolic syndrome, higher chances, and cancer of the endometrium. So obesity overlies all these areas, and this is how we need to come to the diagnosis by ultrasound. In the ultrasound report today, what happens is I see many patients who have acne and hirsutism have seen the dermatologist. They've been asked to get an ultrasound done. The ultrasound doctor makes a note that this is PCOS. Now, a sonographist can never make a diagnosis of PCOS because PCOS will have at least 2 criteria out of 3 present. Now, just because the ovaries are looking polycystic, we normally call it polycystic ovarian morphology. And that has definite criteria that the ovarian volume should be more than 10 ml and there should be more than 12 follicles of 2 to 9 millimeters in diameter seen in each ovary, and it should have an equidense stroma. So the sonologist needs to actually highlight all these characters rather than just saying that the ovaries look polycystic. The second thing is about the periods. Now, normally in the first year post menarche, that if a girl reaches her first period, she gets it at the age of 12 or 13. For the first year, she may have erratic periods. We don't really worry. And if she has periods for 21 to 45 days in the next 3 years, we do not worry about it unless she's got heavy periods which are causing severe anemia. But irregular periods are considered when we have 8 cycles per year. We have more than 90 days for any one cycle after 1 year after achieving period, or by the age of 15 years if she still hasn't attained menarche, or 3 years after breast development she still hasn't achieved a period, she needs to see the gynecologist. And when irregular menstrual cycles are present, a diagnosis of PCOS could be considered, but at the same time not confirmed diagnosis, only a suspicion until the girl has reached the adult period. The reason being that in the adolescent period, there are many girls whose ovaries look polycystic. And secondly, you're doing an ultrasound post per abdomen because they are not yet sexually active. And hence, you do not get a correct reading of their ovaries. And hence, we say just keep them under suspicion. Don't confirm the diagnosis, because once a patient is labeled as a polycystic ovarian syndrome patient, it becomes a lifelong title for that patient, and hence we need to be very careful when we make such a diagnosis. Where acne and hirsutism is concerned, you all as dermatologists have seen this very often, so I'm not going to go too much into it, but we know that there are no universally accepted tool available for assessment today of hyperandrogenism, which may be in the form of hirsutism and acne, though there is the available of the Ferriman-Galway score, where we say with a score more than 8, it would indicate hirsutism. And this is something we must remember, that many girls come to us with already laser done, even at the age of 15 and 16, because the girls don't want to go around with a lot of, hair on their upper lip and chin and beard area. They've already done laser, etc., and come back. And unless we ask them the question as gynecologists, have you done something to have you used any laser? Have you done any dermat therapy? Because we see the small stubble of hair which are there, and the typical hair, that is the terminal hairs which are seen, which after laser too, if, it does show to some extent. And unless one does a careful examination, we may completely miss it. So this is something when they say that you have to wait during this FG scoring, they say that the terminal hair should be at least more than 5 millimeters in length. Now, who allows their hair to grow that much before seeing the doctors? So today, with so many centers, cosmetic centers available, I think a lot of girls are already undergoing a lot of cosmetic treatment before they reach us as to the gynecologist. And of course, we also have a presentation of alopecia where the Ludwig score is used for a female pattern hair loss. So the biochemical hyperandrogenism means how do we diagnose this hyperandrogenism? And that can be, of course, the clinical diagnosis, or it could be a biochemical. Now, where the biochemical is concerned, there's a lot of confusion over it. And therefore, we have to make sure that the patient should be off medical therapy, which involves reducing androgens in circulation. And when we do that, then, we can get a correct report. But at the same time, there are many, many methods of assessing hyperandrogenism, which we are not yet able to confirm what gives you the best results. So if you look at the scenario of irregular periods, we manage them with various therapies. I'm not going to go into these details because this is something which we'll discuss probably in the practical management when we have our panel discussion. And, oral contraceptive pills becomes a major treatment which we do. And as a matter of fact, we have created a consensus statement on the use of OC pills in PCOS ovarian syndrome in India. And IADVL has been one of our collaborators. We had a consensus done. And if you all read up on this, it would really help you a lot to understand which patients you could use OC pills and which you should not. So the second scenario comes with PCOS and infertility. As these girls grow, they get married, and then they have a problem with fertility, and then they come back to the gynecologist. And where we find that they have a problem with fertility, mainly because of their ovulation dysfunction, whereby because they've got irregular periods, they have no proper ovulation happening, and it delays pregnancy. And this occurs because of the poor oocyte quality, because of the hormonal imbalance which is present in these women, increased insulin, increased androgens. There is a poor oocyte quality, there's poor endometrial receptivity, and besides that, it can cause problems with gestational diabetes and hypertension, as I told you. So it can affect fetal viability also. So it affects implantation, it affects fetal viability, leading to abortions, and it can also lead to fetal loss when there is uncontrolled diabetes occurring in such women, where the woman has not been assessed in good time during pregnancy. So the best practices for the management of this infertility in women with PCOS has been based on global WHO guidance, whereby we say that lifestyle intervention is the first recommendation in obese women. That holds true even for adolescent girls. First, a lifestyle intervention is very important, especially if they are obese. So 80% of girls are obese, and that's what we must remember, that we must guide them on losing weight. Of course, there are various other methods, giving pharmacotherapies, giving them metformin, reducing their insulin resistance, and bariatric surgery is only recommended if the BMI is more than 35 kg per millimeter square, and if lifestyle therapy fails, she's just not able to lose weight. We are concerned about bariatric surgery in such women because when they get pregnant, it can lead to fetal undernutrition, and therefore bariatric surgery is the last option if nothing else is working. We use injectable gonadotrophins or hormones to create better ovulation. We resort to assisted reproduction, and all this has been done with excellent results. But many people have tried acupuncture, herbal therapies, where there's no clear evidence as of now. So with PCOS and assisted reproduction, what we have found is that whether it's necessary whether we get better results in PCOS women or whether we get poorer results in PCOS women. But today it has been shown that when we stimulate PCOS women, we get many embryos, and we prefer not to transfer the embryos in the same cycle, but we freeze all the embryos and transfer embryos in the cycle where the hormones are very normal, rather than in the cycle where we have induced ovulation, where the hormones are very high and there's a mismatch between the hormonal levels and the endometrium where the embryo implants. And hence it is this freeze-all which has helped us to improve pregnancy rates and get better pregnancies in women who have got PCOS. So if you look at the weight, how does weight affect assisted reproduction in our own data with 434 PCOS patients? If you look on this right-hand side, we find that we get more number of eggs. Now, these are the normal weight patients, the overweight patients, and the obese patients. You'll find that you get better pregnancy rates, you get better fertilization rates. Everything is better in women who are with normal weight compared to the obese weight. All statistical significance, pregnancy rates are much higher in the normal weight patients as compared to the obese patients. In the live birth patients, live birth rates are also higher, much higher, almost twice as higher as those women who have a BMI of more than 30. And therefore, we need to make sure that we ask these women to lose weight prior to getting pregnant. But that is another issue, that is the obesity, how it affects. The second thing is how hyperandrogenism affects fertility. Now, this is an excellent study which has been published in 2018 in Gynae Endocrinology with 574 infertile PCOS women, 20 to 35 years with a normal BMI. There were two groups, one with 244 with hyperandrogenism and 330 women without hyperandrogenism, and they were treated with assisted reproduction. And what was found is that the amount of injectables used was much lower in patients with in group 2 patients, and abortion rate was significantly, sorry, in group 1 patients, and abortion rate was significantly higher. In short, what was shown is there are more embryos produced in the PCO patients. There's a less gonadotrophin cost, less cost of the injectables, but increased abortions. And therefore, it's recommended that all patients who have hyperandrogenemia with PCOS, it is important to do a freeze-all approach, wherein you don't transfer the embryos in the same cycle, freeze the embryos, bring the hyperandrogenemia under control, and then transfer the embryos. And that gives us better results. Coming to the third scenario of PCOS and pregnancy. Now, this is shown very easily well that patients who have got PCOS, they have a 3 times higher chance of developing gestational diabetes mellitus. And there's a higher chance of hypertension, there's a higher chance of premature deliveries, and a higher risk of perinatal mortality of the baby. And therefore, we must guide our patients who become pregnant as gynecologists. We tell our patients, we monitor them very strictly, because many of them 3 times more chance of having diabetes, which develops during pregnancy, and that is what we are aiming at. And if, as a dermatologist, you're aware that this woman is likely to get pregnant and you're treating her, it's important for you to know that you cannot give them any anti-androgens, which I'm sure all of you are aware of, but at the same time, it would be a good idea for them, for you also as dermatologists, to guide them that you have a higher chance. You please take care, don't eat sweets, stay off sweets, consult your obstetrician much more often, get your sugars checked more often. And this is something which we always tell our patients, and we try and help them to reduce their obesity, reduce their sugar intake, etc., and make sure that they have a better lifestyle. The last part I want to bring up is the epigenetic contribution to PCOS in pregnancy. This fetal hyperandrogenemia can occur in a woman who's pregnant with high androgen levels. And therefore, we try our best to bring their androgen levels down before allowing them to get pregnant, because it has been seen that when the mothers have higher androgens in their body, even the baby is born with higher androgens, with higher insulin, and this causes increased fetal androgens in female offspring with PCOS patients. And it has been shown that these babies have a chance of having insulin resistance, obesity, and a PCOS phenotype as they grow older. And therefore, this is not a genetic influence which is causing it. Genetically, we know only 10% of PCOS gets transferred to the baby. But it is the epigenetic factors, the high androgen, the high AMH values, the insulin resistance, the obesity, the endocrine disruptors. All this causes problems in the postnatal period, leading to PCOS in the daughters of PCOS mothers. So this is something we must all remember, that in utero exposure of androgens to the female fetus has been also recorded. And because in umbilical cord androgens at birth, we have seen that the PCOS offspring have got higher androgen levels. There is higher levels of testosterone detected in the amniotic fluid, and the increased anogenital distance and sebum production, which are markers of androgen exposure, are also seen in these babies. This is a cartoon of how the brain affects the androgens and the ovarian dysfunction, which I'm sure Dr. Shashank Joshi will fulfill. The last section is the 40 plus PCOS women. There's an increased prevalence of abnormal uterine bleeding. They bleed a lot. They have periods of amenorrhea followed by a lot of bleeding. They have difficulty in losing weight. They develop metabolic syndrome, and they have a higher chance of uterine cancer. So we know that obesity is linked to type 2 diabetes. There is insulin resistance, there is hyperandrogenemia, and all this causes a problem with frank diabetes occurring in 7.5% of them, and by the age of 40 years. And we also know that this high sugar is associated with metabolic syndrome, which is a cluster of cardiovascular risk factors related to insulin resistance, wherein there is obesity, hyperinsulinemia, hypertension, dyslipidemia, atherosclerosis, hyperglycemia, and with obesity comes physical inactivity, atherogenic diet, and all this leads to an increased cardiovascular risk. And this is something which we need to keep in mind. All patients need to be investigated for insulin resistance, diabetes, obesity, hypertension, and dyslipidemia. We know that Asian Indians are at a higher risk of developing this. Ours is the global center for diabetes, and we need to make sure that we assist our patients by giving them the correct advice at the right time. So we know that there's a rising prevalence of cardiovascular risk in South Asia. And here you see that compared to as the years are going by, we are seeing more and more of obesity, more and more of metabolic syndrome in this country. And even in the year 2001, it was rising to twice the amount in what was present. 4 times the amount was in 1970. And there have been a lot of studies which have been showing this. So cardiovascular disease risk is something which increases, diabetes increases, metabolic risk factors increase, the lipids increase, the blood pressure increase. And I must bring this to the point that it is seen more in women than in men. As compared to women, we find they have a higher chance of diabetes and cardiovascular risk as compared to the men post-menopause. So this is regarding the metabolic syndrome and cancer. As I said, there's a higher chance of endometrial polyps and endometrial cancer. The other issues we see are sleep apnea, anxiety, depression, and mood swings, very often seen in younger patients, especially who have cosmetic issues, which I'm sure the psychologist will bring up, and hence I'm not going to go in this. We all know that reducing the morbidity of PCOS is a lot in our hands by encouraging our patients to exercise, eating healthy, reduce obesity, come in for an annual checkup with blood test, including monitoring of lipid profile, sugars, ultrasound, and insulin. So the take-home messages from my talk is that it's important to make a correct diagnosis of PCOS, do it at the right time, and symptoms which are present, we all know, we have discussed it. We need to be asking them the questions which will bring us to the answers which we are looking for. Because a patient may go to a dermatologist only with the symptoms, I've got acne, I've got this hair growing on my face, I've got loss of hair on my scalp. But if the dermatologist asks the questions about her periods, and she asks her to do the necessary investigations or take the necessary opinions from the concerned experts, it will go a long way in giving a better quality life to these patients and having a long-term monitoring, which is extremely important because today we still don't know the cause of PCOS. So block your dates for the PCOS annual conference, which is the 6th annual conference on 2nd and 3rd October 2021. Become members of our society, and there are a lot of advantages in doing so. And these are the patient educational videos which we have created. 5 of them have already been in circulation. They are just 2 to 3 minute videos. And here you have one on cosmetic issues. It's a good idea to circulate it amongst your patients, and they will learn a lot from it. We have got one coming up on diet in PCOS and COVID-19 and PCOS. These are under production and they will be soon released. I thank you all for your kind attention, and I'm happy that IADVL is collaborating with the PCOS Society of India to take this cause forward of giving a better quality of life to our women. Thank you very much.
Thank you so much, ma'am, for that wonderful lecture. I will just wait for you to stop sharing so I can share my screen.
Yes,
and thank you so much.
That.
Thank you so much for very direct messages for all, especially the younger dermatologists who have logged in, for our session today. That sometimes the onus is in the hands of dermatologists when younger women come in for cosmetic issues, yes, something as simple as acne or something as complex as hirsutism. So if we can probably pinpoint the diagnosis at that time, it would be very, very fruitful. At the same time, you also give a very strong message of not casually floating around the diagnosis of PCOS, because it is unfortunately a title which we see being thrown around quite casually in our scenarios, not as dermatologists, but by a lot of other specialists as well. So I think that would be, these are good foods for thought, and we would definitely take more of them up in the panel discussion.
Thank you.
So our next speaker for today is Dr. Shruta Kirti Shenoy. She is the past president of the Psychodermatology Association of India. She's going to speak to us about a topic which again is of grave importance to us as dermatologists, where the mind and skin interact. Now, Dr. Shenoy is the current professor and head of the Department of Dermatology at the Kanachur Institute of Medical Sciences, Mangalore. She's the former head of department at KMC Manipal with a total experience of 31 years. She's worked overseas as a consultant dermatologist in Dubai. Her total number of publications exceed 200. She's received the Dermatology Excellence Award, which was instituted by Systopic Laboratories in June 2004, and is also the recipient of the prestigious Dr. J.N. Shetty Memorial Oration Award during Cuticon, Karnataka, which was held on the 8th of October 2011. Thank you, ma'am, for accepting our invite. Over to you.
Thank you, Dr. Asim. Just give me a moment.
Sure, ma'am.
Am I visible?
Yes.
Hello?
Yes, ma'am.
Yeah.
You are visible and audible, ma'am. We can't see your slides, though.
You can see my slides?
No, ma'am. Not till now.
No. Can you see now?
No, ma'am, you have not started sharing your screen as of now. You are
Okay.
start.
Okay. Can you see now?
Yes, ma'am, it is visible. Yeah.
So good afternoon, everybody. First and foremost, I would like to thank IADVL Maharashtra, especially Dr. Asim Sharma, for inviting me to address you all. And he told me initially that it is a case-based discussion. So I think I will restrict to very simple approach to psychodermatology. I won't be talking much about theory, because theory nowadays, at the touch of your finger, you get everything in the internet. So I'll base my discussion mainly on the cases. So coming to the introduction, I'll be talking about the skin-psyche relation. Now, as dermatologists, we all treat the external skin disease. But we have to remember that virtually, basically any skin condition we can consider as a psychodermatological condition. The reason being, the skin lesions are visible on the skin surface, and the patient sees it and the others see it. So definitely, especially in chronic diseases, there is some emotional impact on the individual. So what I feel and what is true is, we should not treat only the skin disease. If we are treating only the skin disease, treating partially, that is, let's say 50% of the problem. But if we treat the emotional problem, if we tackle the emotional problem, what is the psychological impact? If we take care of the psychological impact, we will be treating the patient in a more holistic approach. So in any chronic disease with lesions on the skin surface, we should treat the skin as well as the mind. Now, coming to the psychodermatological conditions, as I told you, each and every condition we have to consider as a psychodermatological condition, because any skin disease, even if it is present for 2-3 days, the patients come running to us saying that they have itching, they have rashes. Now, this psychodermatological conditions, there's a very simple classification by John Wu, and this everybody is familiar. It is classified as primary psychiatric psychodermatological conditions. Under primary, what it means is basically the person has a psychiatric disease, whether it is schizophrenia, anxiety, or depression, and all the skin problems are secondary to the primary condition. So under primary, we have dermatitis artifacta, delusional infestation, trichotillomania, etc. Coming to secondary psychiatric psychodermatological conditions, Secondary means basically the patient has skin problem, whether it is psoriasis, atopic eczema, or vitiligo, and all the psychiatric issues are secondary to the skin problem. So basically, examples are depression, social phobia, which vitiligo patients face. And thirdly, we have psychophysiological conditions. So what is this? Psychophysiological conditions are those conditions which are triggered, which appear because of stress and which are also aggravated because of stress. And again, there are so many conditions in dermatology, for example, acne, atopic dermatitis, urticaria, psoriasis, which can be triggered by stress. So as I told before, I would like to emphasize that any patient with skin disease, whether it is acute or whether it is chronic, let us view in a more holistic way and treat the disease as well as the impact on the patient's psyche. Now, coming to psychiatric problems in a dermatology patient. Now, whenever we see psychodermatological cases, it may belong to one of the four groups, what I told. That means there is a direct link between the skin problem and the psychiatric problem. And the second group is, it is just coexistence. That means just like a person with atopic dermatitis may have diabetes. So it is just coexistence of psychiatric disease with a dermatology problem, but we don't call it as a psychodermatological condition. It may not be related. It's just coexistence. So during my lecture, I'll be giving you some examples. Now coming to the general approach. Now, how do we approach a case of psychodermatological condition? So we all are familiar with history taking, but in the psychodermatology case, we have to lay more emphasis on psychosocial history. Psychosocial history means the psychological factors. How is the psychological state of mind? How is the state of mind? What is his nature? Does he mix with others? And how is he in the family? How many family members are there? And are they supporting him, especially when he has some chronic disease? Is he getting support from his family members, from his friends, from his relatives? How is his interpersonal relationship with his peers, with his friends, with his family members? So all this constitutes a psychosocial history. And second thing is, now this is a mnemonic cross. That means people now, psychodermatologists who are a little bit interested in this subject, we follow this mnemonic where we'll be reviewing the psychiatric symptoms. And thirdly, I'm very fond of questionnaires because as dermatologists during our college days, during our MD days, we were not trained to take a history, and we are specialists only in dermatology. And another factor is in a busy OPD, we may not have sufficient time to take the psychiatric history, and many of the doctors, many of the dermatologists may not feel comfortable. So I strongly recommend, I use questionnaires in my practice, and I strongly recommend the use of questionnaires for people who have some interest in this subject. Now, I told you about the psychiatric review of symptoms. So basically the mnemonic is, depressed patients seem anxious, so claim psychiatrists. So as per the mnemonic, D stands for depression. So you have to take history about depression, which we all know. Then P stands for psychosis, whether they have some psychotic symptoms, they are hearing something, they are imagining something. S is substance abuse, that is alcohol abuse as well as illicit drugs. A is anxiety, we all know about anxiety. S is somatization, that means somatization, they will be all right, but they will have certain symptoms like chronic pain syndrome, chronic itch or vulvodynia, orodynia, penodynia and others. Eating disorders doesn't come under our specialty. C is cognition. So a person may have dementia. So a person, an elderly male, he may talk something, he may tell some history, but we can't totally rely because he may be forgetful. And P, personality disorder. So some patients have borderline personality. So if you remember this mnemonic, then the doctors, dermatologists who are interested in psychodermatology can take history on these aspects. Now, coming to questionnaires, I'm very fond of questionnaires and I use it regularly in my practice. Now, there are several questionnaires. You can choose whichever you are familiar. So I'm very fond of PHQ-9 and PHQ-2 for depression. And one thing about these questionnaires is they are free. You can download, you can translate it on your own. You don't have to take permission, and you can use it for your studies. And PHQ-2 is the first two questions of PHQ-9 constitutes PHQ-2. And GAD-7 also is, you can download from the net. It's a very simple questionnaire for anxiety. And these three things I usually routinely use in my practice. And the last one is a body dysmorphic questionnaire, BDD questionnaire. This is also very simple, and this is also very useful for dermatologists. Now, coming to PHQ-9 questionnaire, as I told you, there are 9 questions and you can translate it. All the languages are available on the net. You don't have to take anybody's permission. You can do studies. You can give these studies to your PGs. And in the PHQ-9, if you feel it is too long, the first 2 questions of PHQ-9 constitutes PHQ-2. So PHQ-2 is recommended for a quick screening. Now, dermatologists who are very busy, who see more than 100 patients per day, you can give this handout, PHQ-2. So these are only the first 2 questions of PHQ-9. That is lack of interest or pleasure in doing things and feeling down or depressed. So each has got a number, and 3 and above, more than 3 and above is significant. Now, GAD-7, again, it's a generalized anxiety disorder questionnaire. Again, there are 7 questions, very simple, the patients can understand. Again, there is a scoring that is more than 5, 5 to 10, 10 to 15, and 15 to 20. So, depending, less than 5 is almost normal, not significant. So, I make it a point whenever I suspect these problems, whether it is depression or anxiety, I usually give out these questionnaires. Now, BDD questionnaire, again, there are 5 questions, and this is again a very simple questionnaire. And if the answer is yes to any one of the questions, then it is very suggestive of BDD. Now, I'll be coming to the cases. Now, case 1, this is a case of extensive fungal infection with depression. Now, there was this young man aged 26 years who had chronic relapsing tinea for the last 2 years. And when I took the psychosocial history, it was quite sad because he had this tinea recurrent fungal infection. And what happened is he got a fairly good job, and he got engaged to a person from the same village. And what happened is the news spread that he had an incurable disease, and the engagement was called off. So he was extremely depressed that the engagement had called off, and even in the house, his family members were sort of distancing him. And when he came to us, we gave a psychiatric referral because I was working in Manipal. We had our psychodermatology liaison clinic, and he was diagnosed with moderate depression, and he was given antifungals as well as antidepressant. But unfortunately, he was lost for follow-up. So this is a typical case of a secondary psychocutaneous disorder. That means the patient has a primary skin disease and the depression is secondary to the skin problem. So the treatment for secondary psychocutaneous is here he was given escitalopram 10 milligram, and we also treated him with oral antifungals, but he was lost for follow-up. Now coming to the next case, this is a 20-year-old female who had acne. Now as you can see here, there is some amount of PIH, there are active lesions, as well as on the left cheek, she has a excoriated lesion. Now, she was started on oral isotretinoin for 2 months. And at the end of 2 months, when she came to me, she expressed a low mood and she said she's not interested in working. She was working in a real estate office. And there she said she's not interested in the job and she was very sad and she was not allowing anybody to take a picture. So overall, she had a very low mood. And so I gave her the PHQ forms and she scored 9. In the PHQ 9, she scored 12, which indicates moderate depression. And BDD questionnaire also was given where there was a positive response. I've told her to, this is a recent case, I've told her to meet the psychiatrist in a hospital, but then again, she is not so keen. I think I have to talk to her once again. So the rate of depression in acne is 2 to 3 times more common than in general population. And 10% of all acne patients have some level of clinical depression. SSRIs are helpful for depression as well as for body dysmorphic disorder. Now, case 3, this is the case of psychophysiological condition. That means a person with skin disease which is aggravated by stress. Now, this was a 19-year-old physiotherapy student. She presented with vitiligo involving more than 20% DSA. So when I took the history, she said that she had a lot of stress. Her parents wanted to join MBBS and she faced extreme stress while preparing for UG NEET exam. And this she felt was a trigger. And within 1 month of the exam, she developed lesions all over the body. And when she came to us in a first year of physiotherapy, we treated her with phototherapy, topicals, but the vitiligo continued to progress. So this is a typical example where stress has caused the skin problem. So psychophysiological conditions, as I told, these are disorders which are triggered or aggravated by stress. The classical examples are psoriasis, atopic dermatitis, urticaria, and vitiligo. So in psychophysiological conditions, stress reduction measures are helpful. That means basically anything which lowers the stress. You should advise them diaphragmatic breathing and do some yogas, mindfulness. And also there is a technique called as JPMR, that is Jacobson's Progressive Muscle Relaxation. Now coming to case 4, a 58-year-old female complained of insect crawling sensation over the skin since 6 to 8 months. She had this firm, unshakable belief. In the earlier stage, in the early part of her disease, she was not much bothered, but towards the end, after a few months, it troubled her a lot. In fact, she said every day she used to get up at 12 o'clock midnight, wash all her clothes and wear new set of clothes. So this was a routine. And she was diagnosed as a case of encapsulated delusional infestation. Nowadays, the term is delusional infestation rather than delusions of parasitosis. But she did not have any other comorbidities. So the psychiatrist has treated her with tablet risperidone 2 milligrams daily. And she showed very good improvement after 2 months. She said, although the problem didn't resolve, she was slightly troubled by it and she was not getting up in the night to wash her clothes. So overall, it was quite okay. She was under control. And one interesting thing is her 2 sons also had similar delusions. It is called as shared delusions. So this is also reported in delusional infestations, where the other family members also share this delusion. So delusional infestation can be primary or secondary. Primary means that is the sole delusion. They do not have any other psychiatric illness. Secondary means it is secondary to schizophrenia, depression, anxiety, etc. And also patients with other conditions like patients with substance abuse, hepatic conditions, renal conditions can get this delusional infestation. And one important thumb rule is any young patient less than 30 years who complains of delusions of parasitosis or delusional infestation less than 30 years, we have to screen for drug abuse, illicit drugs. So less than 30 years, we have to screen for drug abuse. Whereas more than 30, we should think of all the various other conditions like hepatic conditions, renal conditions, and also if nothing is evident, then we call it as a primary condition. So drug of choice earlier, some years ago, we were all fond of using Pemozide, that is a first generation antipsychotic. But nowadays, because of the EPS, extrapyramidal side effects and cardiac toxicity, it is no longer used. Nowadays, the second generation, especially aripiprazole and risperidone, has been used. But one problem is in second generation, the problem of EPS is less. But with second generation, metabolic syndrome is the problem. That means they can get this hypertension, diabetes, weight gain. So this we should watch out. Now, case 5, this is a coexistence of a dermatological and a psychiatric problem. As I told you, all conditions are not psychodermatological. Now, this patient is a 35-year-old female. She was married for 18 years with 4 children, and she had very minimum melasma, very early stage. In fact, it was hardly evident. But she was underweight. She was 36 kgs, and she appeared to have very low mood. When I just questioned her about her mood and other things, she started crying. And then I knew that there was something more than which meets the eye. So she complained of physical abuse by her alcohol husband, who was also hypersexual. And I gave her the PHQ 9 form. She scored 15, and GAD 7, she scored 8, indicating moderate depression and mild anxiety. So I feel the reason she came to me was a sort of cry for help. She just wanted to get out of the house and meet some doctor. So actually, this condition, we don't call it as a psychodermatological condition. It's just coexistence of a dermatological problem and a psychiatric problem. So for a holistic management, just treating her for melasma is not enough. So once you detect, we have to treat the patient as a whole. So we have to refer her to the proper to the psychiatrist for proper and complete management of her condition. So to summarize, I would like to tell that all patients, more so the chronic patients, we have to screen for psychiatric conditions. All of us may not be trained and we may not have the time to take a detailed history. We can take some brief history. But if you're not familiar with history taking, if you're not comfortable with history taking, then I strongly recommend you all to use questionnaires of your choice. You can also use this HADS questionnaire, Hospital Anxiety Depression Scale. That's also popular. So you can give questionnaires, you can ask questions to the patient, you can take a detailed history. And our job as dermatologists is to treat the skin lesions. So personally speaking, I always prefer to screen the patients. Then always I prefer, if a psychiatrist is available in the hospital, it's always better to refer to a psychiatrist because we are not trained to deal with psychiatric problems. Now, it so happens that patients are resistant. In fact, when we tell them about psychiatrists, they start, they don't feel comfortable and they say, I don't have a mental problem. So in such cases, maybe if you are familiar with the psychotropic medicines, we can start the psychotropics on our own. The thumb rule is start on a low dose, follow up regularly, at least once in 15 days, and then you can slowly titrate. But you should always review at regular intervals. So thank you very much. And I think I'll take up questions during the panel discussion. Thank you.
Thank you so much, ma'am, for that wonderful talk. As always, you've shown us how there are so many other diseases where we do not consider, psychological involvement or psychiatric involvement, and we don't counsel. So there's so much to learn from each time I hear you talk. And I have that question specifically earmarked for you, ma'am. It's a googly question. How we can counsel patients to visit a psychiatrist when we're sure that there is something lingering. But we'll come to that in the panel discussion. We'll quickly move to our next and final speaker of the day before we break for a panel discussion. So our next speaker is Dr. Shashank Joshi. He's the founder vice president of the PCOS Society of India. He's going to talk to us about skin as a neuroendocrine organ. Dr. Joshi is a well-known endocrinologist in Mumbai at Leelavati and Bhatia hospitals. As I mentioned, he's the founder vice president of the PCOS Society of India. He's the dean of the Indian College of Physicians, the president of the Indian Academy of Diabetes. He's the past chapter chair of India AACE and the past president of the International College of Nutrition. We're happy to have you on board, sir. Over to you. Shailendra, can you just help Dr. Sharang, please?
Yes, sir, sure. One second. Sir, you are on mute. Please unmute yourself, sir.
Hello, am I audible?
Yes, sir. Yes, sir. Now audible.
So for brevity of time, I'll be very quick. Today we are talking of skin neuroendocrinology and PCOS. And our focus though is predominantly dermatological. I'm going to give you a very quick overview of a couple of points related to the same, because we know that skin has a huge neuroendocrinology, and we all know that there is a biological basis to it. And therefore, when we look at skin neuroendocrinology, we know that skin is a classical target for melanotropins. And we know that their actual production is predominantly local. We also know that the hypothalamic pituitary adrenal axis is expressed in the skin, and that includes CRH, urocortin, POMC, and products like ACTH, alpha MSH, and beta endorphin. And obviously, we know there's a lot of paracrine and autocrine mechanism here. Cutaneously, what is necessary from an endocrine standpoint is vitamin D and PTHRP, apart from acetylcholine and catecholamines. And these are all having impacts on environment, stresses, UV light, and the skin response to stress. So remember, skin, we all know, is a response to stress. We just heard the biology and psychology of it. So when you look at the endocrine mediators of receptors on dermal and epidermal units for precise control for activity, we know that skin neuroendocrine system communicates itself with a systemic level. And we also know that there is a clear-cut challenge which is there. And we know that for systemic homeostasis, a lot of hormonal and neural pathways induce vascular, immune, and pigmentary changes. We also know that skin is a source for hormones and neurotransmitters, whether it is the epidermis, dermis, or the adnexal structures. And the epidermis is predominantly vitamin D, PTH, some catecholamines, some endorphins, or TRH. But when it comes to dermis and adnexal structures, we get hormones like androgens and estrogens, which can have an impact from a PCOS standpoint. So if you look at the exocrine and endocrine skin units, you know the exocrine unit, all of y'all as dermatologists know it very, very well. But the endocrine unit has two superficial and deep plexuses. And we all know very, very clearly that the endocrine unit of the skin is something which has been modulated by a lot of endocrine orchestra of hormone receptors, as well as the keratinocytes, the Merkel cells, the T lymphocytes, the melanocytes, and so on and so forth. So if you look at the epidermal and dermal endocrine unit with basement and membrane, we know that there is a lot of sensory and autonomic nervic influence. And we all know that on the epidermal endocrine unit, there is an integrity barrier, melanization barrier, vitamin D production, and metabolic and insulin, which is crucial. But insulin becomes more relevant when it comes to the dermal endocrine unit. And clearly, when we look at the environmental factors on epidermis and dermis, clearly we know that they impact the pituitary, the hormonal, and other organs, and that data is very well recognized. In the PCOS, which already Madam Durusha has alluded to, we know there is ovulatory dysfunction and hyperandrogenemia. and a lot of endocrine and neuroendocrine abnormalities are seen in that of FSH, LH. And we know that the androgen excess is reducing the GnRH pulse frequency of progesterone and also causes a rapid LH pulse secretion, increasing the ovarian androgen production. And this persistent of rapidity of GnRH secretion is not well known, but we know it starts from puberty. And therefore, we know that obese girls get a lot of androgen excess with LH pulsatility and androgen excess, which has been affected very clearly. And obesity has a clear role. And skin is one of those manifestations of insulin resistance, particularly acanthosis nigricans. And we know PCOS has phenotypes and genotypes. And in India, particularly, because it's a global phenotype, what we see predominantly is insulin resistance. And probably the dermatologists are the first people who come into contact. So if you see somebody with acanthosis nigricans, with hirsutism, probably that's the first way you are seeing insulin resistance and metabolic syndrome. And eventually they want to get diabetes and hypertension. So clearly we see a very, very metabolic phenotype, particularly from our geography. And that's something which we are concerned about. And we know that as Indians, we have insulin resistance metabolic syndrome. And skin is a classical manifestation of acanthosis nigricans, apart from acne and androgen excess, which is also clearly seen compared to that. So obviously the culprit is insulin resistance, and we know that dermis is affected. But when we look at the systemic manifestations, clearly we know that when there is excessive insulin, there is decreased SHBG production by the liver, increased androgen excess, and disordered release of FSH and LH. And then, of course, you get the androgen excess and oligoovulation in PCOS. So clearly, the insulin resistance is the root cause of PCOS, and you can have metabolic and reproductive consequences. And we need to hit both these targets, and that's why we need to develop drugs like metformin, which impact women's health. And there's a lot of data suggesting that metformin actually can impact skin as well. But remember, lifestyle is crucial, as emphasized by the previous speaker also. It is lifestyle, and that makes all the difference to improve skin health as well. And to improve insulin resistance, 90% of insulin resistance can be managed by lifestyle, by eating less, by eating on time, portion control, cutting the carbs and fats, improving protein intake, eating slowly, eating more in the morning and less at night, eating the right kind of food, trying to do at least your 10,000 steps per day or doing some yoga asanas, building some muscle, sleeping on time, and of course doing some digital detox. So I'm going to stop here. I'll be happy to take questions at the end of the panel. I thought that I have not taken cases as was requested for me to do, but during the question and answers, I'll be happy to answer any questions which people have. Thank you so much.
Thank you so much, Shashank sir, for that brief yet very, very powerful and striking talk. A lot of take-home messages from the few slides that you did show. Now we'll quickly move on to the panel discussion, and we already have a few audience questions which I'll be taking as we go forward. Please do send in your audience questions targeted to which faculty would want them to answer. So let's start with the panel discussion. I would request all the panelists to please switch on their videos and audios so that I can see everyone. So we have Dr. Durusha, Dr. Shashank Joshi, Dr. Shruta Kirti Shenoy, who have already been introduced. We also have two other eminent experts on our panel, Dr. Abdul Latif and Dr. Gulrez Taib Khan. So Dr. Abdul Latif is an additional professor, and he's a division in charge of the Psychodermatology division at the Department of Dermatology and Venereology at the Government Medical College in Calicut. He is the sitting president of the Psychodermatology Association of India. He's a member of the European Society for Dermatology and Psychiatry. He's been a speaker in national and international conferences, has many publications under his belt, and his areas of interest include psychodermatology and cosmetic dermatology. Welcome you, sir. And our last panelist is Dr. Gulrez Taib Khan. She's a consultant dermatologist at Saifi Hospital and at Gynec World Mumbai. She's the managing committee member of the PCO Society of India at present. She's also a member of the Psychodermatology Association of India and a coordinator for Abhiyan PCOS, which is a multi-institutional consortium doing a lot of good work, which I'm sure we'll discuss during the panel discussion. Welcome, Dr. Gulrez. So for the first question, I'm going to move towards Dr. Abdul Latif. Now, a lot has been spoken on the biopsychosocial model of health in general, but specifically for us on skin health. So apart from the diseases that Dr. Shenoy mentioned beautifully in her presentation, are there any common skin disorders or diseases where we are missing this particular approach?
Are you audible, Azim?
Yes, you're audible, sir.
Yeah. So thank you for the outset. Let me thank the organizers, especially Dr. Azim, for inviting me for this program. And so far, I was very interestingly hearing the previous three talks. So in the talk by Shruti Madam, she has very beautifully mentioned all the categorization of the disease with various examples. So in short, the single answer, if you expect from me, I will reply that all dermatological cases has to be considered as a psychodermatological case unless otherwise proved. Because many cases that may be either psychophysiological conditions or there will be the dermatological condition will have secondary psychiatric comorbidity, or the group with less symptomatology or the less chunk of the patients that is belonging to the primary psychiatric group, where the number of cases are less. But the still more higher group is there will be a primary skin condition producing secondary psychiatric morbidity. But almost all skin conditions, the example of infection like fungal infection, Madam already mentioned, and the acne already mentioned. So almost all conditions producing psychological morbidity. So we should be able to understand and recognize this as early as possible.
Understood. Thank you so much. Thank you for that succinct answer, sir. And as Dr. Shinoy pointed out in her presentation, for a lot of us who have busier OPDs and a lot of us who are not very good with history taking, there are obviously questionnaires that can help the cause. A lot of them available as a resource on the website of PDAI, as I imagine. We'll be sharing links with all of you after this session. So as you rightly pointed out, sir, the psyche and the skin do interact. We've heard a lot about that today, and we will be discussing more of that during further slides. So I'll move back to Dr. Durusha very quickly. So ma'am, you mentioned quite beautifully how we should not miss androgen excess in its own merit, but also we should be very careful in giving out a diagnosis of PCOS, as it's a very debilitating diagnosis for a patient to have throughout life. So do you feel that we are missing out on patients in the quest for diagnosing PCOS, and we're not treating androgen excess in the foray? Because that's what I see us doing as dermatologists. Unless a patient is a frank case of PCOS, we usually deter from giving patients, anti-androgen medications or OC pills. So is SAHA syndrome, which is what you mentioned at the beginning, which is seborrhea, acne, hirsutism, and alopecia, is this enough for us to undertake anti-androgens as a treatment option?
As I mentioned, that the Rotterdam criteria need to be met with. At least 2 out of the 3 criteria need to be met with. And if your clinical evidence of hyperandrogenism is present in terms of acne, hirsutism is already present, then that is clinical hyperandrogenism. Now, whether you have clinical or biochemical hyperandrogenism doesn't matter. It does not mean that if there is acne, you have to look for testosterone levels being high. It's not necessary. So if there is evidence of acne, evidence of hirsutism, or evidence of SAHA, then in that case, we need to have one more criterion to be fulfilled. Either the polycystic ovarian morphology on ultrasound, or the presence of oligoamenorrhea. That means irregular menstrual cycles. So these 2 conditions need to be met with, any 2. And then you can label the patient as PCOS.
Understood, ma'am. But what I was also trying to ask was, so in patients with adult acne, sometimes we do not find any other biochemical markers, at least early on. And sometimes we do not find anything on a transvaginal ultrasound and no menstrual irregularity. But we still end up getting good success rates with drugs like spironolactone and even a combination of cyproterone and ethinyl estradiol. So that was what I was trying to get at. What would be your approach for cases like that?
See, that particular clinical manifestation in dermatology could be better probably answered by you as a dermatologist as to what are the causes of it occurring. And yes, the same treatment would help the patient, because when we are giving them oral contraceptives, we know that there is some hormonal function in these kind of patients. So when we are giving them oral contraceptives, we are actually binding the sex hormone binding globulin increases. It binds the androgens and it reduces the chances of any hyperandrogenemia. So I think it could be an early onset of PCOS possibly, and these patients, when they become obese, the problems increase. It could be something like this, but probably the thought has to be kept in mind, but not labeled as a PCOS. What, according to you, could be the other causes of having SAHA? That's my question to you.
Before I answer that, ma'am, I would want my other colleagues to probably take that question. I would definitely give my inputs at the end. Anybody, any dermatologist in the panel? Dr. Gulrez, would you like to go forward?
Yeah. So, as we understand acne per se, we know that one of the etiologies is the androgen excess. So, even in normal acne vulgaris, where androgen does play a role, when we give anti-androgens as treatment, they would show results. And so maybe that would be the explanation, I guess. Yes.
True.
One of the 4 factors is androgen excess.
Absolutely. And in fact, acne vulgaris itself also has another pathway via the insulin-like growth factor, IGF-1, which I have mentioned.
Yes.
So any subclinical hyperinsulinemia could also be a cause for acne. And we often see even teenage acne, for that matter, is because the sebaceous glands are overactive and they're producing more sebum. So sebaceous overactivity is the prima facie of acne. So anything which basically targets that would probably give rise to acne.
So here, Rasim, I would just like to mention, as you mentioned, pubertal acne. Puberty itself is a state in which there is hyperinsulinemia. It's an hyperinsulinemic state, and as a result, you see a lot of acne in the teenagers.
Precisely. So I think great points over there.
Most of the time, Azim, what we are seeing is, even though these clinical manifestations are there, if we are investigating the biochemical hyperandrogenism will not be there. The serum level of testosterone, that will be normal.
Yes.
So there will be sometimes there is more sensitivity, hypersensitivity of the target organs. That will be sometimes the reason for this. Where also even treatment with anti-androgens may be effective. That may be the reason for the response.
True.
And here again, see the sensitivity of the target organ, as Dr. Shashank has already talked about skin being an endocrine organ. We know that there is an active conversion happening from testosterone to dihydrotestosterone at the level of the skin. So that any trigger which will increase the activity of 5-alpha reductase and cause increased levels of DHT in the skin means that there is, cutaneous hypersensitivity to the hormone.
True. I think that was a very, very important message right there. Even like we see in cases of alopecia and adult acne, sometimes not only the circulating androgens, but the increased receptor affinity at the level of the hair follicle or the sebaceous gland, that itself has to be taken into consideration, which we probably can't prove biochemically, which may be another reason why these patients are improving. So my next question is going to be to Dr. Shashank. Now, so once a case of PCOS, always a case of PCOS. I'm not putting it mildly at all. But what is the impact of PCOS? You showed us how patients, and in fact, as a part of the PCOS Society of India, you also have bariatric surgeons on board where you recommend bariatric surgeries, beyond a BMI of 35. So, what would be the duration of treatment? Lifelong? Is it a lifelong disease? Do we treat it like we treat diabetes? Do we tell patients that it is a lifelong disorder, or is there a road at the end? Is there some light at the end?
So PCOS is predominantly a lifestyle disease. It's a lifelong disease. It has a lot of heterogeneity in it. And if you look at the phenotype-genotype correlation, you will probably get maybe multiple clusters which will emerge. Having said that, the underlying theme is very simple. It is insulin resistance. Most insulin resistance doesn't need bariatric surgery. It is lifestyle. It's eat less, walk more, and appropriately handling is not happening. We are in this crazy lifestyle syndrome where PCOS is there. We also get lean PCOS, which is often having a lot of androgen excess, and that's something also which we need to handle. So I think it is a lifelong disease. We definitely will have impact of PCOS later in life. You can get type 2 diabetes. You can also have some associations with malignancies. In fact, Madam Durusha, with the International Society for PCOS, representing PCOS Society of India, came out with the very nice 100-page guidance on PCOS, which was published a couple of years back. I would urge all of you all to go through that document, which actually clearly tells us the consequences of PCOS, which also includes some malignancies. So I think PCOS should not be ignored or dismissed. It's a syndrome. It has clusters. It has an androgen excess cluster. It has a menstrual irregularity cluster. It has a metabolic consequences like diabetes, dyslipidemia, fatty liver as a cluster. So there are different clusters. And once we are able to assess it, then we need to triage it and appropriately manage it. But as I said, 80% is a lifestyle disease with a little bit of metformin and little bit of maybe a couple of other things. Obesity definitely is a forerunner. And, you can see that if there is insulin resistance, you don't need to do an insulin level if you see acanthosis nigricans. So, it's simple to treat, but sometimes the simplest of treatments are the most complex because adherence to them long-term are very difficult. And that's the challenge we face, that people take cosmetic treatment, people might take reproductive endocrine treatment, gynecological treatment, but necessarily will forget after a couple of years that once their cosmetic endeavor is over or their reproductive endocrine or the fertility issue is over, then they forget that they had PCOS. And then they'll end up with heart disease later, or they'll end up with diabetes later, or with a malignancy later. And that's something which we need to recognize. And that's why definitely it's a condition to be watchful and mindful throughout your life.
Wonderfully put, sir. I don't think anybody could have summarized that better. A lot of clusters, all of us play our parts at different clusters, but not forgetting what it is in the long run and being very, very mindful when a patient has PCOS. I think those are very, very strong messages for the audience. So we move to non-pharmacological measures because as Dr. Durusha put, pharmacological measures everybody knows. All of us know how to treat. But what are the non-pharmac measures that we take, take in course for PCOS? So Dr. Shashank mentioned about lifestyle. He mentioned it quite in detail, so I won't go over it. Dr. Gulrez, would you want to cover the portion with diet?
Yes. So diet. I mean, when we talk about lifestyle measures, and we have to counsel a patient with regard to diet, it's frankly, we just can't tell them that go lose weight and come back to us. The PCOS Society, in fact, has taught us that we just can't let the patient go like that. We need to be a part of their management system and guide them with regard to each and every aspect. So, especially with adolescents, the patients that we see, we know that they have a diet routine which is literally horrifying in the real sense of the term, because it consists of fast food, it consists of irregular timing of eating food. What I do with my patients is I try to ask them to maintain a food diary. I tell them about whatever they put in their mouth, they're supposed to note it down, and the timing of the day as well. And then they come back with it to me, and then we discuss it out. How I go about counseling about the diet, I mean, I tell them that they have to eliminate something called as scrap from their food. And that is something that they have to do instantly. C stands for, it's an acronym, CRAP. C stands for colas, R stands for refined foods, A stands for alcohol, and P stands for packaged foods. And just a few weeks back, one of the fathers of the patient added S to that, and he said that's Starbucks, because the kids spend half their time at Starbucks currently. So giving them this kind of direction as far as food is concerned, what not to eat, and then of course guide them with regard to eating healthy rather than dieting. And a very important message that should be given to them is that it's not that they go on a diet and then they come back to their junk and irregular eating habits. They have to eat healthy from now onwards, and that would benefit the entire family as well. In fact, the person in charge of the kitchen, I try to have this discussion in their presence so that the message is taken home, and as a family they are able to execute a good healthy nutrition for the patient as well as for the family.
Wonderful. So diet which can be sustained for a longer period of time and in which there is collective effort from everyone in the family. So I think those are two cornerstones. Dr. Durusha, ma'am, can I ask you about sleep? And there is research now. In fact, I self and Dr. Gulrez were discussing yesterday about sympathetic overdrive in patients of PCOS. So how are these to be managed, and how do you counsel patients, for sleep cycles? Do you tell them to use fitness watches or bands, or how do you go about it?
No, I think we find that the sleep pattern is usually disturbed in two kinds of patients. One, those who have anxiety and depression, and they complain of lack of sleep, or they follow very difficult sleeping timings, wherein they are sleeping through, on social media at night, exposed to TV, too much of visual with the digital world, and then they sleep at 5 in the morning and get up at 1 in the afternoon. So there's an erratic way of living, and therefore sometimes they say I don't sleep enough. It's because they look at the time period when others are awake and they are sleeping, and they are awake and the others are sleeping. So in short, their concept of not sleeping enough is sometimes not correct. We have to go into the details of from what time they go to sleep and what time they wake up, and you'll find that most of them are sleeping 7 to 8 hours a day, and there's no issue with that. The other patients are the obese patients who do have sleep apnea patterns, and that is something which is can be very harmful to their health, and that is something which requires assessment and correction. So these are the two sleep pattern changes which I see in patients quite often. Coming to treating that sleep disorder with bands, etc., is something which really I have not attended to personally, but we definitely like to find out what is the cause of this problem. So we do the questioning, and once we realize that it is more of maybe a psychological problem, then we do ask them to see the psychologist. And if we feel it's more of a sleep apnea problem, then we refer them to the sleep apnea testing. So this is the way I handle it, and there could be many more others, but these two are the effective ways of handling it.
Thank you, ma'am. Obviously, sleep also comprises, and makes up for our mental well-being. So this is where I'll reintroduce Dr. Shenoy. Ma'am, what do you feel? So non-pharmacological measures to manage not only PCOS, HAR syndrome, metabolic syndrome, how important is mental well-being in all of this?
Yeah, mental well-being is important, not only for cutaneous diseases. For each and every disease, mental well-being is very important. So I think in terms of sympathetic overactivity, if the patient has a sympathetic, in fact, you mentioned that sympathetic overdrive, there are many non-pharmacological interventions, Basically, you should ask the patients what they are fond of. If they're fond of music, you should encourage them to hear more of music. And some people like to do meditation. So especially nowadays, mindfulness meditation is gaining popularity. But some people, when you tell them, they say, doctor, please don't talk about meditation. I don't like to do yoga or meditation. So you can't give a recipe. You should see what the patients prefer. If they prefer to do yoga, you can ask them to do yoga in a proper way. You can also advise mindfulness meditation. And there's also something called as JPMR. So all these are non-pharmacological interventions which can reduce the sympathetic overdrive. But there is no single recipe. You should talk to the patient. So ideally, I would prefer to refer these patients to a clinical psychologist who can spend some time and see what the patients can do and advise accordingly.
Thank you, ma'am. Thank you so much. Before we move to the next question, we've got a lot of audience questions which have come in. So I'll try to take them one by one. The first question is by Dr. Vandana Punjabi. I'll direct this to Professor Shashank. Sir, can you elaborate about serum insulin levels, fasting and post-glucose for insulin resistance?
He's on mute.
Yeah.
Yes, sir. So the first question is directed to you.
I heard the question was fasting and post-lunch insulin levels are a research tool. According to me, they have no value in clinical medicine. People still keep on using them. If you have a good fasting and postprandial blood glucose, you have reasonable degree of lipid profile where triglycerides are elevated, you have fatty liver, you have acanthosin aggregans, really don't need to document and follow those insulin levels at all. You need to put them on lifestyle and metformin period. And just a quick point on the sleep pattern and sympathetic overdrive. Madam Durusha very rightly pointed out about the disrupted biological clock. In fact, I'm a part of the Chronobiological Society for India, and we are disrupting our clock. We need a good 7 hours of sleep from 10 to 5 p.m. There's good research to show that too much of sleep is not bad, but less than 5 hours of sleep is not good, and more than 10 hours is too much, and that's very crucial. And sometimes a simple pill, which is not a sleeping pill, but it's actually a physiological hormone called melatonin, 3 milligrams at night. If you give it to them, that resets the biological apparatus and also can reduce sympathetic overdrive. And you see that in many PCOS women, particularly after they have finished their reproductive age, get a little bit of hypertension. And all you need to do is just correct their sleep and add a little bit of melatonin, add an extra hour of sleep, and you can see that blood pressure, glucose, everything getting corrected. So you need to do sometimes simple interventions which are meaningful. And sometimes some of the yogic practices reduce sympathetic drive. We have good data to suggest that if you do pranayama, yoga, vipassana, they all have been documented, including chanting some of the mantras. That there is a good data to show that they can reduce the autonomic sympathetic drive.
Thank you, sir. I think some very, very important points here. Melatonin is also something we use a lot in our hair research. We're finding a lot of good results with that in androgenetic alopecia. We have topical formulations. I'm not sure how much role they have to play in our scheme of things. So I have another question. This question I will direct towards Dr. Durusha. For lean PCOS, now Professor Shashank already mentioned it is a hyperandrogenic state. But what advice and what counseling will we give to lean PCOS patients? Because the whole issue about metabolic syndrome is out. We can't counsel them about that. So what should our counseling be regarding these particular patients?
So as a matter of fact, 20% of our PCO patients are lean. And there are also quite a few of them have insulin resistance. So it's not that we don't see insulin resistance in women who are lean. In short, we have to, of course, in their case, we are not talking about weight reduction, but we are talking about increasing their muscle mass. So by increasing the muscle mass, there'll be a better insulin sensitivity, and that will help them to probably, if they've got irregular periods, get their periods more regularly and to have a better quality of life. So I think what helps the lean patients is more of exercises which are resistant exercises, like say weights, etc. Those are the exercises, they help them a lot because it helps to build their muscle mass and helps to increase the insulin sensitivity. So that is what we recommend to our women who have this problem.
Another question directed to you, ma'am. How long can one continue oral contraceptives in PCOS?
See, as a matter of fact, we prefer not to start oral contraceptives in a young girl who's an adolescent prior to the age of 18. But unless there is a very, real reason for us to start, especially if she's having, very, very heavy periods or having severe dysmenorrhea, after we have ruled out any uterine pathology, then we may think of starting it. Ideally, we would prefer to start only progesterone. In women and girls who have got delayed periods, we give them progesterone, either micronized progesterone or any other, progestin, which we start on day 16 of the period and give it for 10 days. So that is day 16 of period, starting from day 1 of the period coming and being counted as day 1. First 15 days, no medication. Day 16 to day 25, that is for 10 days, we give 10 milligrams a day of medroxyprogesterone, or we give micronized progesterone 200 mg a day. Now, when we do that, then after stopping the tablet, the patient gets a period. If she does well with that, then we continue only with the progesterone therapy. But if she doesn't settle with that, or she has a lot of side effects, or in case her acne increase with that, or her bloatedness increases, then we may switch to the oral contraceptive pill. But once she's past the age of 18 and she's confirmed as a PCOS, we could start her on OC pills, and those could be continued regularly with an annual checkup coming in once a year, where we are evaluating the patient for any contraindications of OC pill, where we do not give to such a patient, by investigating her, adequately once a year and making sure that it's safe for her to continue the drug. She can continue taking it till as long as she doesn't wish to be pregnant, and then we stop it when she plans a pregnancy.
Great. Thank you so much for the detailed answer, ma'am. We'll just take 2 more questions because there are questions literally pouring in as I'm scrolling. This one is for Dr. Abdul now, the next one. Suppression of emotions and, the pattern of skin diseases. Are there any skin diseases as such where we see a lot of, emotional underplay happening? Any 4 diseases or 5 which you want to point out?
Emotional underplay, usually in the common conditions like psoriasis, that is very common. because you can get if there is a sudden emotional outburst. I have seen one patient's father died 1 week prior to the acute exacerbation. Then after the death of the father, the patient developed extensive vascular lesions and ultimately went to the exfoliated dermatitis. And the response to treatment in psoriasis with stress, to whatever drug we are giving, the response is very, very less. So that is one common condition. Then lichen planus I have seen. I still remember one of the professors in our medical college, Calicut. He came to me with extensive lesions of lichen planus in the legs, hands, and everywhere. Then after seeing the lesion, I asked him, "Are you suffering from any stressful event?" Then he told me, "Yeah, I have got a sudden stressful event regarding my daughter academics." Then he was treated by one of our dermatology professors, but there were not much response. Then I gave him relaxation therapy and some other counseling in addition to the dermatological management. To my surprise, he responded very quickly. And there were not much lesions after that, and the existing lesions started subsiding very quickly. Then other common conditions like atopic dermatitis and prurigo nodularis, very common and very vexing problem as far as dermatologists are concerned. And recently we have conducted a study and published that almost 40% of prurigo nodularis have got depression or anxiety. And other common conditions, acne and all, we just discussed now. Then many of other conditions like systemic sclerosis and chronic long-term diseases, there will be the quality of life will be markedly affected, and many of them are depressed because the normal life of the patient is markedly affected. And any disease that is on the visible part of the body, and they have to do some work, especially in the public, so that is affecting them markedly. That will affect their quality of life, and that will produce adjustment disorder. There will be social withdrawal. Ultimately, they will be becoming depressed. So these are the common conditions, and I already mentioned any dermatological chronic long-lasting dermatological conditions, unless otherwise proved, that has to be considered as a psychodermatological condition. And we have to manage it psychodermatological, where the dermatological aspect has to be managed, the psychiatric aspect has to be managed, and psychosocial aspect also has to be managed. So we will have to do dermatological management, psychological interventions, and pharmacotherapy has to be instituted simultaneously in this patient.
Thank you, sir. Thank you so much for that detailed answer. I do agree with you. Any skin disorder, unless otherwise proved, has to be dealt with, in a psychodermatology manner. And that's why I put this slide. Thank you so much for bringing me onto this slide. So we have discussed today about mental well-being in PCOS patients and other skin disorders as well. Now, the next question I'm going to put forth to Dr. Shashank. So thank you for giving us the answer on insulin levels, which was your opinion. That was a very frank and honest answer. We truly appreciate that. But investigating patients for hyperandrogenism, is there a minimum essential? Because as we usually get the tip of the iceberg done, but if you want to get an entire panel done, it will set the patient back by something around 5 figures. So in a resource poor setting, what are the absolute minimum investigations that you would definitely get done?
I don't think you'll get set by 5 figures. There are some very good packages available from various labs, including Metropolis, which have these PCOS packages, which are at 2,000-3,000 rupees. I think you should not get that. You should not be that negative about it. And I said insulin levels very frankly because if you are seeing acanthosis nigricans, you should not be doing insulin levels, honestly speaking. So there is no upper end and there is no lower end. Okay, for this. But to document androgen excess, if you have a free testosterone, it's good enough. If you have bioavailable testosterone, it's mainly for hypogonadism, and it's more useful in men and not in women. So you rule out that bioavailable completely. If you have free and total, it's great. Androstenedione often may be high when the testosterone free may be normal. Adiponectin is a research tool. DHEA and 17-hydroxyprogesterone tell you that the source of androgen is adrenal. And sometimes when you do a stimulated, 17-OHP, in late onset congenital adrenal hyperplasia, there it is useful, but that's a very rare event. Then, when it comes to insulin, I told you that it's a research tool. Fasting PP and lipids give us all the answers. 17-OHP can be useful. A glyco-HB fasting PP definitely is useful. But, simply, it depends on the age and the manifestation. So if somebody is coming with irregular cycles on the third or fifth day of the cycle, then I would definitely like to do an FSH, LH, prolactin, T3, T4, TSH, probably a free and a total testosterone, androstenedione, DHEA, 17-OHP, fasting PP glucose with lipids, maybe a glyco-HB, all if the patient can afford it. So as I said, that you need to triage it. But if I see that there is acanthosis nigricans, androgen excess in that patient, probably a TSH, FSH is all I need sometimes in the least minimal category with a little bit of prolactin maybe. So, you have to definitely decide what we can do and what we cannot do. But when you see an androgen excess phenotype, you need to recognize that that can often be done. Sometimes we do free and total from an androgen standpoint because, as Gulrej rightly said, that, in the skin you have this dihydrotestosterone, which is not mentioned here. But many a times for dermatologists, doing a DHT, free testo and testo can be helpful and useful because you often use a lot of finasteride or 5-alpha reductase blockers. So sometimes you need it for making treatment decisions. So, if there's resource poor, I would still say do lifestyle, give metformin and or maybe give some inositol, and you'll be good. Okay. You don't need to do all these tests at all. But if you want to do it, then be guided for that individual case because as I said, this comes in clusters. So it depends on the cluster you are seeing. If you have an obese person and androgen excess with acne predominant, the investigation will be different. And I would be looking at adrenal androgens as well. If there is a lot of, nodulocystic acne. If there is going to be predominant hirsutism, then, my likelihood of doing a DHT with a little bit of alopecia is going to be more with free testosterone and androstenedione. So if I have to really then decide, then I have to really subcluster them and then decide using the resources available with me. But most often we'll end up doing some packages which are finite and fixed. Some of these labs have been, I think, probably because ma'am is a reproductive endocrinologist. Her husband has designed some very good packages. So for me, it's a no-brainer. I just tell them to use that package. And there are 2-3 packages. One is extended package, which is a little more expensive, which many a times we have to do. But otherwise, we do a baseline package, and that covers most of it. And it comes in one group, so it is easy for us. So I'm not propagating anything, so don't get me that I'm being unethical here. But sometimes it works out to be a little more economical, so that it's easy for the patient to benefit at large. Because sometimes they already come with a list of tests with us. Because there are some other pathology labs which do some 150 tests, including some metals and heavy metals and all that. Then it becomes a nightmare to go through the reports, takes us another 10 minutes. Then 1 or 2, with our Google and WhatsApp, being so powerful, competing with us, that they will underline with yellow markers, put some red flags there, go through the reports, triage them, and then sort them out. And the diagnosis is already staring at you. They need to really be counseled for help. And they will then Google and then say, my androgen is there. So I'm a man inside me. I'm doing a genetic test. So I actually have had ladies, even last week, even in this era, a lady had high testosterone. Mother went and did karyotyping because she thought that probably this is a man, because she was getting very aggressive and angry. So this happens, and this is a true story. So and on the karyotyping, and I said, then how much did you spend? Then they had spent 25,000 because the karyotyping was expensive, not needed. You need to preserve it. We need to triage it. We need to do what is necessary and guided by clinical common sense. But many a times, as I said, skin, you can actually triage it better. So there's no simple answer for this. Again, I would reiterate, and probably Madam can send that International PCOS document, which Madam was the author of, actually has each of these investigations spelled out in a very nice way. And it's a good guide for anybody who's interested in this whole PCOS gamut. When to do what test, what is the level of evidence, what is the strength of recommendations, with Helen Taylor from Australia, who was then the president of the International PCOS Society, and Madam was representing India that time, Dr. Guduru Shah. We have got that guideline in place. So try to go through that document. And I think I'm certain that Madam or Pinali will be happy to provide the document to you.
Can I come in? The guidelines, thank you, Shashank, for bringing up the guidelines. They are available on the PCOS Society website. And as a matter of fact, we had conducted almost 12 webinars in the year 2019 to discuss these various guidelines which have been developed with very big organizations like ASRM, ESHRE, and the Australian group. So I think, and the Center for Research of Reproduction and PCOS. So it's a real excellent document. Besides that, the document which we in India have developed is also excellent, which is on OC pills and PCOS. So both those could be useful to dermatologists.
Great. I think there was some lag on my behalf, but definitely after the webinar, I would be contacting Pinali, and we would be circulating these. This is where I think all of us come into play. All specialties, again, something where we all converge and try to find some semblance, some diagnosis, some treatment. I'm going to start with Dr. Shenoy. Ma'am, a case of pruritus vulvae. We've discussed this before, you and I. Some people say it's a subset of an obsessive compulsive disorder. It's an undiagnosed malignancy. It's a deep-rooted phobia of STD. So many patients who come to us demanding, repeated viral markers despite not having, despite having a dubious history. So for you, what is pruritus vulvae, ma'am? How do you manage such cases?
Pruritus vulvae, first and foremost, you have to rule out all dermatological causes, which I don't want to elaborate. All the gynecological and dermatological causes have to be excluded, and if they are there, have to be treated. And then after all this, there is a group of disorders, not a huge group, where the symptom is just pruritus. It is intractable pruritus. It won't be, they would have gone to the gynecologist and we would have treated them, and they don't respond to any of these measures. And this is a very small group. So possibly this group of conditions can be considered as a type of somatization disorder. Somatization, where there are certain somatic symptoms which are referable to certain parts of the body. So somatization disorders, the symptoms can be referable to the whole body. They can have generalized pruritus, they can have pruritus vulvae, they can have orodynia, penodynia, vulvodynia. So just like that, they can be intractable pruritus. So when I was working in KMC Manipal, all these so-called idiopathic or cause not known, they would have gone to the gynecologist and we would have treated them. I used to ask them to come to a psychodermatology clinic. We were running a psychodermatology clinic. And most of the times, some of them, not all, they would have some mild to moderate depression. So I believe all these patients of recalcitrant pruritus vulvae should have a psychiatric referral, and a detailed history should be taken. Maybe there is some history of sexual abuse, which we can consider as a post-traumatic stress disorder. So I think a psychiatrist is the best person to take a more detailed history. And in a few patients which I saw, they had a mild to moderate depression. And they were started on amitriptyline, and many of them improved. In fact, I have one patient who has been coming to me for the last 3 years. She is a 60 plus postmenopausal female, intractable pruritus. And earlier I treated her with oxepin, she improved. Then she had a relapse. I started her on amitriptyline. She doesn't have any psychiatric comorbidity. And then I gave her a course of mirtazapine, and now she is doing well. So basically, pruritus vulvae, we have to rule out local dermatological and gynecological causes. And if it doesn't improve, we have to refer to a psychiatrist. That is my take.
Understood, ma'am. I'm only going to ask Dr. Durusha for any additional inputs for this, this particular subset of cases.
Yeah, of course, pruritus vulvae is the commonest symptom in our women who have vaginal infections due to the infection which is present in the vagina. That's the commonest cause. Trichomonal infections, candidiasis are the commonest. And if we find a patient who has absolutely no vaginal discharge and she's only got simple pruritus, more often than not, I have found that they turn out to be diabetic. They always tell you, no, I'm not diabetic. I do their blood sugar levels, and there they are. Impaired glucose tolerance is usually present. So the message I would give is, if you have a patient with pruritus vulvae where you cannot determine a cause, get their blood sugars done. Very often you'll find them high.
Great. Thank you, ma'am. You did mention in one of your earlier presentations that we are a hub of endocrine disorders, metabolic syndrome, and diabetes mellitus, so it would be worthwhile getting that done.
Yeah.
Great. So I think we have discussed this in parts. We've discussed a dermatologist approach. We've discussed pointers by Dr. Durusha. We've discussed an endocrinologist approach. Psychosocial aspects, Dr. Abdul, can you just quickly tell us about non-excoriae acne when it comes to us? We usually don't delve into the psychological aspects of acne or, simple acne vulgaris or even adult acne. So I can see sir's video moving. Is sir available? Else I would request, yes. Sir, can you please tell us quickly about psychosocial aspects that you consider while when you see a patient of acne vulgaris or adult acne?
He's on mute, I think. He's muted.
Yes.
Yes, the psychosocial aspects of acne, because we know this is mainly occurring in the younger age group. So younger age group people, they are highly conscious about their beauty. So even a single acne lesion on the face, that's very important as far as they are concerned. And if the number of lesions are on the increase, their anxiety regarding the lesions are on the increase. So many patients, not only the acne excoriae, simple acne I'm telling, the psychological impact is very high, especially during the first few years of the onset of the acne lesions. They will be highly embarrassed by seeing these small lesions on their face. So far, their face was so clean and beautiful, now developing these lesions. So naturally, what's happening is there will be some pressure or some comments from their peer groups. So that will be very difficult for them. So gradually they will be looking to the mirror and there will be some social problems they will develop. So gradually social withdrawal in some group of people, the difficulty to go to the school, and these are the things we are seeing. And in a smaller group, that will gradually go to the other adjustment disorder or severe depression and anxiety is developing in this group of disorder conditions. And in the acne excoriae group, they are frequently manipulating these lesions and producing severe scars or prurigo-like lesions on their face, and excoriations, ulceration, all these are being produced. So the psychosocial impact and stress in acne lesions are on very, very high. So we have to counsel these patients. So counseling aspect is very important. One thing, an adolescent education, the various changes they are developing during the adolescent age, that we have to teach them, the psycho education, that's very important. And group therapy, that is one very good thing what we can do. We can collect few youngsters and discuss the various aspects of acne, how they are dealing, and what are the problems they are facing in their schools and in the society. So that is very, very useful in this type of cases. Then other things, specifically supportive psychotherapy in specific individuals, depending upon what is their psychological problem, we can identify and do that also.
Thank you, sir. I think that is the whole motive of today's webinar: a holistic approach. All of us coming together and doing a group, consult, and probably a group consultation later. Maybe that would become, the order of the day. So we'll break for a very quick discussion by Dr. Gulrez Taib Khan. Now we all know about the microbiome, and all of us have read about the gut-brain-skin axis. There's a lot of research going around about the topic for all inflammatory disorders and autoimmune diseases, not only in in general medicine but also in the purview of skin. So we know that a microbiome is simply a collection or a collective set of microbes and their genetic material which resides in any anatomical niche, which could be the gut or the skin. And the human gut is home for more than 100 trillion bacteria, as we quite well are aware of. But Dr. Gulrez, can you just take over from here, share your screen, and quickly take us through the gut-brain-skin axis and what we should be, just practical aspects of what we should be taking care of in our daily OPDs.
Yeah, so is my screen visible?
Yes.
Yeah, I'll quickly. We have had this talk. Dr. Shenoy did mention about the emotional distress and the depression that an acne patient goes through. So also Dr. Abdul. Now, when that is happening, is there an impact of that on any other system of the body? This is what I wanted to quickly highlight. And that's where we need to understand what is microbiome and how dysbiosis plays a role in causing disease. So, Dr. Asim, I don't seem to be able to, yeah. So Dr. Asim has already mentioned about what is the microbiome. And for a good skin conditioning, it's important to have a working skin microbiome, a good, properly working skin microbiome. There are, apart from bacteria, there are viruses, specifically bacteriophages, fungi, mites. They all constitute our cutaneous microbiome. And this cutaneous microbiome is impacted by multiple external factors as well as internal factors, and that includes the hormone, the sleep cycle, the stress, and external factors like sunlight and physical activities. And all these references have been made by the previous speakers. Now, if you see the gut microbiome, of course, there are multiple 100 trillion bacteria. And in fact, they say that our body has less human cells, but more microbial cells. Diet plays a very important role in the composition. And just to highlight the gut-brain-skin axis, which, the psychodermatology group, as well as I think the PCOS, society, it's a common context that our gut is a major immune organ. It has Peyer's patches. It does secrete cytokines and immune cells. And this does not only remain in the gut. Via circulation, it actually can impact distant organs like the skin. And it can even help to improve and modulate the immune status of the skin. So we know, and there is emerging evidence, though not, it's more investigative currently, that the dysbiosis can impact conditions like atopic dermatitis, psoriasis, acne vulgaris, and it's the emotions. In fact, I mean, this cycle, if you see, it talks about how emotions of stress and anxiety and depression can actually alter the gut microbiota. That can stimulate something called as the polysaccharide, lipopolysaccharide biosynthesis pathway, increase intestinal permeability, and reach the skin and cause diseases like acne. Similarly, the Western diet, which we know there is evidence with regard to Western diet and acne, that actually again impacts the gut bacteria, triggers the IGF-1 pathway, and as a result causes acne. In fact, the skin dysbiosis along with the gut dysbiosis both can impact this IGF-1 pathway and trigger acne. So it's actually this aspect that I wanted to highlight, that the underlying mechanism of emotional stress as well as the external factors could be on our the gut bacteria as well as the skin bacteria, and that could possibly trigger the underlying molecular events which would manifest in a disease. And current status of probiotics, of course, we really don't do that very often. And what we need to, I mean, it's a very use of probiotics would be a very simple and a cheap way of managing diseases in case that strong association has been established. So it's just that, when we are discussing the holistic aspect of skin diseases, microbiome and its impact on the skin and diseases, I thought it would be a good idea to share. And Dr. Asim agreed about that. So.
No, I totally agree with you. Because this is again one of those things which we are seeing a lot now. In fact, we have a very common skin brand now, which where we have probiotics specifically designed for atopic children, which a lot of us are finding decent success with. But yes, FDA approvals for a lot of things that we do use are a little far now.
Nazim, I have got one question. That is role of prebiotics. Any
role of prebiotics?
But prebiotics in this case, because that is highlights the foodstuffs.
Exactly. So, what they say is that we are, the probiotics that are there, they are really not approved by the, FDA, and effects are really, outcomes are not established, though there are multiple brands available. However, prebiotics and probiotics in the form of diet and food can be something that a dermatologist and, other specialties could consider. So we need to, kind of give it a thought when we are guiding patients.
Agreed. So we'll quickly move. Now I have just 2 slides left, 2 case scenarios. So there's a 20-year-old female patient who came with the complaints of hair loss and widening of the partition, which a lot of us do see. Irregular menstrual cycles. She had amenorrhea for more than 3 months. Her BMI was 26 kilogram per meter square. She had polycystic ovarian morphology, as was rightly pointed out by Dr. Durusha in her presentation. Her TSH, prolactin, testosterone-free and total androstenedione, DHEA, 17 OHP levels, all within normal limits. No acne, no hirsutism, mild acanthosis nigricans over the neck area, and DHT levels were found high. Now, she's been to multiple gynecologists. She refuses to take all oral medications except for a short course, and that too she wants off and on. So I'm going to bring in Dr. Shashank for this particular case. First of all, is this a case of PCOS? I think he's, I can't see him as of now. Dr. Durusha, can I transfer this question to you, please?
Yeah, I think since she has amenorrhea and she also has, oligoamenorrhea, and she also has polycystic ovarian morphology, I would label her as a case of PCOS for sure. Number one. Second thing is DHT is also a kind of androgen, which is high. And that again could be explained by the fact that, as we discussed before, that in the skin, if there is a lot of DHT which has been released or secreted, then it can cause a lot of hirsutism. And probably this patient, I'm not sure whether she had hirsutism or not, but by giving her something like an alpha reductase suppressor, we could help her to lower her DHT levels and also to reduce the hirsutism to some extent. Oral contraceptives would help her tremendously because she would get her periods regularly. She would also help, it would help in reducing the DHT levels, and it would also help to reduce her evidence of hirsutism gradually over a period of time. If there was, I'm not sure whether you had mentioned hirsutism.
No, ma'am, she didn't have no hirsutism.
She didn't have hirsutism, okay. And the last thing is about the insulin. I agree with Dr. Shashank when he says it's not necessary to do the insulin and post-glucose and fasting. But if a patient does not have acanthosis or does not have evidence of any insulin resistance, but you're strongly suspecting it, especially in a patient who's obese, then I do carry out an insulin fasting. And very often I'll find if I do just a post-lunch insulin, I may not get it high, but a post-glucose insulin can go as high as 300 plus. So I think it's a test which we need to decide when to do it. Very helpful in helping us with insulin resistance. I mean, that's what I can mention. I don't know what else you have in mind on this question.
No, that's about it, ma'am. I just wanted to basically point out that this is a frank case of PCOS where DHT levels are proven to be high, and anti-androgens would be the drug of choice in this particular case. I'm also going to integrate an audience question, ma'am, since we're a little short on time. So there's a question from Dr. Rajita Dami-Shetty from Hyderabad. How would a gynecologist's approach change in the setting of significant hirsutism or hormonal acne in a girl under 18?
Yes, in that case, if she has hirsutism and if she has, say normal periods, then I would not be giving her any oral contraceptives because I don't want to suppress her HPO axis. But what I would give her is, anti-androgens, which could help her. Either we would give finasteride or we would give an anti-androgen like cytomid is what I call it, but is something we would give. Of course, before that, we would do the necessary test to know whether it's safe to give it to them.
Cytomid, a lot of us are pretty scared of, ma'am, because of the fulminant toxicity.
No, but we do carry out their liver function test, etc. Give it for a very short period. because I feel it works much better somehow compared to finasteride. And I wouldn't start them first with the other drug, but probably with the finasteride. And if it works well with high levels of DHT, but if finasteride doesn't work, then I do try a short course in that other product.
So what's the dosage of finasteride usually you are recommending, ma'am?
About 5 milligram a day.
And ma'am, just on the same topic, I have a personal question. So since you mentioned flutamide, do you also feel bicalutamide is as potent as flutamide is? Are these replaceable, or do you strongly believe only in cytomide?
No, I'm sorry, I have not used the other one. So diflutamide I haven't used, so I'm not sure about how well it works. Have you? I'm not sure if anyone has used it.
No.
And no, I don't know.
Thank you, ma'am. We'll move to the next scenario. Dr. Gulrez, I would want you to take this on because this is something we frequently encounter. So a 25-year-old female patient diagnosed as PCOS with hirsutism over the chin, upper neck, along with moderate acne. She's already taken, say, about 4 laser hair reduction sessions, but she has economic constraints now, as all of us charge quite a lot for laser hair removal. So she's in a hurry to get results, and she's upset that the laser hasn't given her quick results. So after that, after this, she was started on OC pills, and a psychosocial evaluation was done. But what next? When do we plan the next session, or do we complete the course of anti-androgens? How do we go about treating this case?
So this case, actually, what needs to be highlighted is that the psychosocial aspect. This girl is in a hurry. We have actually not completed all her laser sessions. We have already started her on OCs, but she's still upset. She's in a hurry. So what we did was we tried to understand what are her social circumstances. And when we started questioning her, we realized that there was a lot of pressure from the family for her to get married. And because she had hirsutism, visible hirsutism on the chin as well as the upper neck, the family was concerned that she wouldn't find a suitable groom for herself. And when we probed further, we realized that she even had certain psychosexual issues, which is that when she gets married, there was anxiety in relation to that. So this was basically to highlight that as Abhiyan PCOS, which is a group of 4 institutes, we are a consortium which includes the PCOS Society of India, NIRRH, TISS, as well as something called as Kasturba Health Society, of which Dr. Amar Vaidya is the director. We have undertaken this psychosocial evaluation of PCOS patients. It is actually underway, and very soon we'll be completing the study. This case just highlights the importance of psychosocial evaluation, and as Dr. Shenoy as well as Dr. Latif has mentioned, these aspects cannot be ignored in today's context.
Great. Thank you so much. So I'm moving to the last slide, after which I'll take only two audience questions. So I actually wanted Dr. Shashank for this particular one because I wanted his opinion on inositol. He has already mentioned it. I think he has logged off, if I'm not wrong. He's maybe having some issues. Anybody else would want to take on myo-inositol? Is it as good an sensitizer?
Yeah.
Yes, ma'am.
I could answer on the myo-inositol, and as a matter of fact, we do use myo-inositol in women. Of course, those who are not able to tolerate the metformin, though metformin becomes the gold standard. If for some reason a patient is not able to tolerate a dose which he requires, then we add on the myo-inositol, and we are able to see some good results with that too. But a head-to-head comparison of myo-inositol and metformin has not yet been done in context, and therefore, as of today, we don't have enough evidence on it. But in short trials, it has been found to be useful, especially in adolescents, wherein they have irregular periods. You put them onto a weight loss program and you add the myo-inositol. It definitely helps in getting back the regular periods. So whether it's the weight loss which is helping, whether it's a myo-inositol helping them to get rid of some weight loss, because it works like an insulin sensitizer. It's a product which is present within our bodies. So it's found that in PCO patients there's a deficiency of myo-inositol, and that is how we are supplementing. implementing it.
Great. Ma'am, would you also want to take one audience question on metformin?
Yes, sure.
So there is Dr. Maya Vedmurthy from Chennai. She has asked, is the sustained release formulation now the preferred form of metformin, or if not, how do you position it?
See, I normally prefer to use the regular metformin, but if a patient can't tolerate it, then we try the sustained release one. And many patients do tolerate it when you use the sustained release one. But there are some patients who don't absorb it at all. Some patients have told me they take it and then they pass it out the next day. So it's like just not absorbed. But there are few of those. But I use it only for those patients who can't tolerate the simple form of the regular form of metformin, which is a dose given 2 or 3 times a day, depending on how much dose you want to give to the patient. Whilst the sustained release is usually as a single dose or a maximum a double dose.
Understood. Oh, thank you, ma'am. Thank you. And my next question is going to be to Dr. Shenoy. Likewise, ma'am, I call these the almost theirs because we don't know how much of the original drug they can actually mimic. So Lactium as a GABA analog, N-acetylcysteine obviously has moved from a humble paracetamol overdose antidote to now being extensively used for us in tic disorders and obsessive compulsive disorders. But where do we place them, ma'am? Where do we place these two molecules in the gamut of conventional psychiatric medication?
Yeah, actually, Lactium, there's some publications about this drug. I'm not too sure. Abroad, it's available as an OTC. That means it speaks for the safety of the drug. And I have some limited experience. The few patients that I've used, in one patient said that he could sleep well. And another patient said, mostly it was with regard to sleep. They said that they had a peaceful sleep. So actually, I can't comment much. It's an OTC drug abroad. And I think we should use more and be more familiar with it. So coming to N-acetylcysteine, I think high doses have been tried in trichotillomania. And again, I've used it in one patient, because one thing, a favorable thing about N-acetylcysteine is it is a natural drug and it's not a drug actually. It is very safe. From that point of view, the dermatologists feel happy, that there are no side effects. So I've used in one patient and there was some improvement in trichotillomania. Of course, the dosage is 600 milligram 3 times daily. You can start one tablet twice daily to maximum you can increase to 3 tablets. And one patient, there was some response, as such, trichotillomania is not a very common condition and patients don't come for follow-up. So the one patient that I used had some response to N-acetylcysteine. So I think before trying psychotropics as a dermatologist, I think for trichotillomania, we are justified in trying N-acetylcysteine.
I agree with you, ma'am. I agree with you absolutely. So I think we've come to the end. I'm going to take one audience question that will be for Dr. Gulrez. Now you mentioned about diet in PCOS. What is the role of eliminating dairy? And I know you know why I'm asking you this question.
So eliminating dairy, that is a vegan diet is now in vogue. However, eliminating it completely, I think in our day-to-day routine may not be very, very comfortable. However, we know the association of dairy and there is compelling evidence with regard to dairy products and acne. There is also literature on the fact that cheese, which is a dairy product, is actually an inflammatory food. So in conditions like PCOS, in certain other inflammatory conditions of the body, such inflammatory foods actually need to be avoided. And so if it is possible to do so, I think one should do it. But vegan diet is a very difficult diet to keep up with.
I think great was there. In fact, like you rightly mentioned, milk is considered an inflammatory food because of the protein casein, if I'm not wrong.
Casein. That's correct.
To, I think, IGF-1 and then acne. Excellent. So I think we've had a great long session. We are 15 minutes delayed over time, in fact. So quick parting words we'll start with Dr. Durusha. Ma'am, some words for all the dermatologists who've logged in today.
Yeah, I think all you guys are doing a great job. Focus a little bit more on other aspects of skin conditions, of PCOS rather than only the skin condition, and create that awareness so that the girls have a better quality of life in future. That's the agenda.
Thank you, ma'am. Thank you so much. Dr. Abdul?
Yeah, actually, this was a very good experience because a holistic approach and a comprehensive management style, because that is the one which we are actually lacking. So your effort that will channelize the people in thinking and acting in a holistic approach. So this is very useful and continue it.
Thank you, sir. Dr. Shashank is not with us. Dr. Gulrez?
So I would like to say that this is an era of multidisciplinary, approach to diseases. And I think we should collaborate with most of our colleagues in managing a patient very effectively. That would mean a patient-centric approach, actually.
Great. You stole my closing line, so I have nothing else to say after this. Dr. Shalai, ma'am, can we have words from you, please?
Yeah, first and foremost, I'd like to thank IADVL Maharashtra, and especially for the energetic and vibrant and dynamic Dr. Aseem Sharma for arranging this webinar. And I would like to say that, as dermatologists, let us confine and to our specialty. I mean, I'm particularly fond of let us treat as a dermatologist, because we are specialists in dermatology. So as dermatologists, if we treat the dermatological condition, then definitely the psychological impact will come down. Just because the patient has depression, anxiety, we don't have to start them on medications. If you treat their dermatological problems, definitely their psychological aspects will be improved. So I would like to say that as dermatologists, let us treat the skin conditions effectively. Thank you.
Thank you, ma'am. Thank you so much. And I'm thankful to everybody today, for disproving this. This is a common skin health pyramid. All dermatologists are very well aware of this. This is any beauty blogger or Instagram influencer knows this by heart. But there is much more to skin health than simple skin health pyramids and skincare. Thank you all for proving that with me today. I'm very thankful to IADVL Media Cell on behalf of IADVL Maharashtra, the PCS Society of India, the Psychodermatology Association of India. They're doing fantastic work. So I would urge you to go through their websites, download the resources. Therefore, they're freely available for everybody to learn and move forward. I'm also very thankful to FDC Limited for organizing today's webinar and for their unrestricted educational grant, not only for this program, but for all programs that Maharashtra has been doing over the past year. Mokadam sir, our Honorable President, I would like you to end the show now. That's it from my side.
No words to thank Aseem. A really wonderful program, the way you organize it, and I really appreciate your efforts to organize this multi-speciality topic, and it has been done wonderfully. I really thank Dr. Madam Dhurusha Madam, then Dr. Shenoy, Dr. Abdul Latif, Dr. Gulrez, and even Dr. Shashank. So it's really, you have made our task very easy, and you're really helping all our dermatologists to do our responsibility very thoroughly and in the best possible way. And I hope all our dermatologists will definitely benefit with all your fantastic and useful tips. Thank you very much, Dr. Aseem.
Thank you. Thank you.
Thank you, everyone. Thank you so much.
Thank
you.
Bye-bye. Thanks.
Thank you. Thank you.
Thank you, respected doctors. Thanks a lot.
Thank you. Thanks, Shailendra, for everything. Thank you so much.
Thank you, Mr. Shailendra. Thank you.
Thank you, ma'am. Thank you.
Okay, bye, Dr. Aseem.
Bye, ma'am. Thank you so much. And Abdul sir as well. Bye, sir.
Bye, everybody.